In this video, we will discuss about the acceptability, specificity, and potency of GlyTR1 as they have tested this BITE design antibodies, that is GlyTR1 and GlyTR2, on different lymphocytes and the cancer cell lines. And the panel A is about the Glycan binding towards these lymphocytes and the cancer cell lines, and panel 2 is about the GlyTR2 binding against the lymphocytes and the cancer cell lines. And we can see that overall the binding is for the GlyTR2 is high compared to the GlyTR1. However, they have not claimed that things in the paper. They just showed that for both the cases they are able to see the binding. And thereafter what they did is they check this GlyTR1 binding and GlyTR1 binding. Panel C results is for the GlyTR1 binding on different tissue microarrays. So first they check it for the normal kidney, normal spleen, normal liver, and normal placenta. And here the GlyTR1 is conjugated to the FITC, so that if GlyTR1 binds to this tissue microarrays, then it will show green fluorescence. So for this normal organs, that is normal kidney, spleen, liver, and placenta, we are able to see faint green color. And afterwards they decided to check it on the colon adenocarcinoma, and that too at different stages of the tissue microarrays that are collected of this colon adenocarcinoma. And also they used the negative control as a normal colon which is adjacent to the tumors. And we can see that as the tumor progresses from the primary stage T1, T2 to primary stage T3, T4 to distant metastasis, they are able to see increase in the FITC fluorescence. And so compared to the case of this primary stage, or there is very faint FITC, green fluorescence in the normal colon. So this indicates the specificities of this GlyTR1 is more towards the cancer cells, or when the cells acquire the cancer properties, because this GlyTR1 binds to the beta-1,6 branching, which is expressed heavily on when the cells converted into the tumors. So as they are progresses towards the tumor cells, the beta-1,6 branching increases, and this leads to the high GlyTR1 binding, as it binds to the place where there is high density of the beta-1,6 branching. Afterwards, once they validate their specificities for the GlyTR1, now they check the potency or the cell death efficacies of both GlyTR1 and GlyTR2 on different cancer cell lines. And in two cases, that is for the panel D for this GlyTR1 and panel M for this GlyTR2, they have used CD8 plus T cells, whereas for all the other cases they have used PBMCs along with the cancer cells and this GlyTR1 and GlyTR2. And they are able to see that for all the cases there is a dose dependent increase in the cell death. As they increase the GlyTR1 concentrations or GlyTR2 concentrations, they are able to see the cell death. However, the interesting thing that one needs to understand know that the range for the GlyTR1 is in the picomolar, whereas the range for the GlyTR2 is nanomolar, indicating that the lower the range, the better the drug, or better these antibodies. So this indicates that, however, that thing also they have not claimed. This is just my observations. What they have claimed is that both this GlyTR1 and GlyTR2 shows the cell death with dose dependent increase in this. Both this GlyTR1 and GlyTR2 shows increase in the cell death with dose dependent increase in their respective concentrations. So in together, this whole figure shows the acceptability as it can bind to the different cancer cell lines, the specificity as it is more specific towards the cells that have more cancerous property, and the potency as they can kill the cancer cells if there are immune cells, more specifically CD3 positive immune cells or the T cells are present. So this is what they have concluded from this figure. If you need to understand more about this results in detail, you can go through the reference that has been provided in the description. That's all for this video. Thank you for your time.